Hi, I'm Rachel Jantia, Geriatric Medicine faculty at McGovern Medical School, and this is the ICARE Geriatrics module, the 4 M's of age-friendly health systems with a focus on mentation. Our objectives are to define conditions that may affect mental and cognitive health in older adults, including dementia, delirium, depression, and social isolation. To ask questions to help clients ascertain their risks for these conditions, and to describe preventative measures to decrease the likelihood of developing dementia or depression in older adulthood. When we think about mentation, we think about something called the 3Ds: dementia, delirium, and depression. Dementia is defined as cognitive impairment resulting in functional impairment of activities of daily living and instrumental activities of daily living. In other words, cognitive impairment affecting function. You can see the mobility module for more information about these functional categories. Dementia can be thought of as chronic brain failure, just the same way that you can think about chronic heart failure, chronic kidney failure. It is a chronic vulnerability of the brain. And it has many different causes, and it may be irreversible or progressive in nature, depending on the cause. Delirium, on the other hand, is a medical diagnosis that is characterized by acute, altered mental status changes that wax and wane, along with inattention, disorganized thinking, and altered level of consciousness. It's a very specific diagnosis. Unlike dementia, again, it is acute in nature. You can think about it like acute brain failure, similar to acute kidney injury, for example. But we do know now that it may cause long-term cognitive deficits in many people affected by it. It's usually precipitated by an acute stressor, such as an acute illness, but it may have many different causes and contributors. We won't focus as much on delirium for this module, because I don't think you'll encounter it as much with your clients, and I want you to be aware that it exists. And then finally, the third D, depression. This is a mood disorder that causes persistent feelings of sadness or loss of interest, which interferes with daily functioning. It can cause inattention, memory impairment, and apathy. And so it may look as if it is presenting as cognitive impairment, or what we call pseudodementia. So you have to be very careful when you're seeing these symptoms to think about, could it be depression? Could it be cognitive impairment, or both? It's important to think about the spectrum of cognitive changes so that if your clients ask you, is this considered normal, you can answer it. So what is normal? What are normal cognitive changes of aging? It's normal to have occasional forgetfulness, actually just like you and I do. For example, walking into a room, forgetting why you walked in there, but eventually being able to figure out, oh yeah, I was looking for this, or misplacing something, but being able to retrace your steps. In other words, it certainly does not affect your ability to function in day-to-day life. It is also normal with aging to have a slowing in your processing speed, but you can still complete the cognitive tasks that you need to complete. Similarly, there might be more difficulty with multitasking, but you can still get individual tasks done. Mild cognitive impairment would be a little step beyond this. And I would describe it as moderate cognitive impairment that does not impact function. So it might be that you lose things and are not able to locate them, but in general, you're able to carry on with your day-to-day activities and care for yourself independently without any issues. When we start to call it dementia is when we have significant cognitive impairment that does impact function, does start to impact your ADLs and or IADLs. So the moment that you need help, for example, managing your medications or your finances, or start to have errors with those things, problems with driving, that would be when it would start to be called dementia clinically. The prevalence of dementia is about 10% of Americans over the age of 65. With another 22% having mild cognitive impairment. Some of those people with cognitive impairment will go on to develop dementia, but not everybody. And then this pie chart shows a nice breakdown of the most common types or causes of dementia, with the largest chunk being caused by Alzheimer's disease, followed by vascular dementia, and mixed dementia, which is typically a combination of Alzheimer's and vascular type dementia. There are some other less common causes to be aware of, and this would be something that a healthcare professional experienced in dementia would be able to ask questions to help distinguish between. It's important to note, too, that there are some reversible causes of dementia, which is one of the reasons why it's so important to be evaluated if you're having symptoms of dementia, because it may be something that's reversible. So your clients might ask you about, how do I prevent dementia or cognitive impairment? The screen here shows some of the things that might increase your risk of developing dementia and related Alzheimer's dementia and related dementias. So what can we do to try to prevent? Well, we want to try to address these things. Number one, quit smoking if you smoke and avoid air pollution. Try not to sit at a bus stop and breathing in the exhaust for an extended period of time. If you do drink in moderation. Avoid head injuries. It's important to think about falls in this setting. So any fall that results in a head injury would be something that increases your risk. And then you want to prevent and manage high blood pressure, high cholesterol, and other things that are going to increase your risk of vascular dementia. Prevent and manage hearing loss. So things that never make it in to your brain because you don't hear them are not going to be remembered, and it's going to exacerbate in cognitive impairment and may actually mimic dementia. Managing blood sugar if you have high blood sugar or diabetes, and maintaining a healthy weight with a healthy diet and exercise are also things that will decrease your risk of the vascular component of dementia. When it comes to diet, the Mediterranean diet is a really great diet to follow. If you're thinking about strategies to optimize your brain health. Sustain physical activity levels, get enough sleep, stay socially engaged. We know that social isolation and loneliness are associated with increased likelihood of developing dementia. And then finally, I'll just comment that there is mixed evidence on whether cognitive exercises like brain puzzles and the like help, but they certainly don't hurt. So it's okay if clients want to do this, and it's okay to encourage it. So how about those people or clients that tell you, I am having memory problems or I am experiencing dementia? What can you tell them? Well, first, you can encourage them to optimize their physical and mental health issues. You can look at the mobility module for this, as well as other parts of this module, to stay socially engaged, as we just discussed. If they are experiencing behavioral or psychological symptoms of dementia, such as anxiety or agitation, it's important to avoid medications that sedate you, and instead focus on multi-component non-pharmacologic management of these symptoms, and they can talk to their providers about this. Again, minimizing high-risk medications that can make cognitive impairment worse. You can check out the medications module for this. Align care with what matters most, like we want to do for all clients. Provide support to caregivers, and encourage clients to complete advanced directives to ensure that the care that they receive later in life aligns with what matters most to them, and that they communicate that with their loved ones and healthcare providers. So how do you ask your clients about memory problems? You might ask, have you noticed problems with your short-term memory? For example, remembering appointments, recent events, or misplacing things. Have you had problems with word finding ability, or the ability to do things that you once did easily, like managing medications, finances, driving, planning out events? Are they harder now than they used to be? Another way to ask is, have other people told you that you forget things easily, or that your personality has changed recently? An answer of yes to any of these indicates high risk of cognitive impairment and should prompt further assessment and screening by a healthcare provider. Remember here that when you're talking to your clients about this, you are not diagnosing dementia. You are only inquiring about possible signs of memory problems that may need to be evaluated by a healthcare provider. This can be a sensitive topic, and so you want to be very careful about what it is that we're doing and what we're recommending to our clients. Let's switch gears now and talk about depression a little bit. Signs and symptoms of depression include sad or anxious mood, loss of interest in activities or apathy, decreased energy, fatigue, irritability, restlessness, difficulty concentrating, sleep or diet changes, suicidal thoughts, definitely. And again, this may mimic cognitive impairment, so you have to have a high index of suspicion for both cognitive impairment and depression when you see these things. Some risk factors for depression include having other chronic medical conditions, experiencing social isolation and loneliness, a lack of physical activity, a family history of depression or mental health illness, and stress. Treatment includes cognitive behavioral therapy, medications, and when it's appropriate, electroconvulsive therapy. These are all things that if somebody is experiencing depression can talk to their provider about. So how might we screen for depression? These are questions you can ask your clients. And the way you want to ask it is, over the last 2 weeks, how often were you bothered by the following problems? And I want you to tell me if it's not at all, several days, more than half the days, or nearly every day. The first question is having little interest or pleasure in doing things, again, over the last 2 weeks, or feeling down, depressed, or hopeless over the last 2 weeks. A score of 3 or more on this PHQ-2 screen should prompt further assessment by a healthcare provider. Again, it's not a diagnosis of depression, but is a positive screen for risk. Now let's talk about social well-being and connectedness. Social isolation is a risk factor for depression, for dementia, and other medical conditions, including stroke and heart disease, as you can see on the screen. Loneliness is the feeling of being alone or disconnected from others. Engaging in habits that promote social connectedness and well-being can improve physical and mental health. And so that's what we want to talk about for your clients. How can you engage in positive social habits to prevent social isolation? There are some resources available to you and your clients in the resource list, but some high notes are to make connections with others by engaging in community events, volunteering, taking a class, doing something new. Take care of yourself while caring for others. So if you are a caregiver for other people, make sure that you're engaged with a routine, take breaks, join a support group. Be active in things like exercise, especially if you can do it as part of a class or a group. And build healthy relationships. So try to listen to others, try to be the kind of person that other people want to be around, be compromising, and find the kinds of people that you relate well to. And certainly you want to protect yourself from abusive people or people that do not share a healthy relationship with you. There is a screening for loneliness that may help someone identify their risk of social isolation called the UCLA 3-item loneliness scale. And you can ask the following 3 questions and ask them to answer whether this is them hardly ever, some of the time, or often. The first question, how often do you feel that you lack companionship? How often do you feel left out? And how often do you feel isolated from others? The higher the score, the more lonely the person is, and the higher the risk. And in general, we think that a score of 6 or more should prompt further assessment by a healthcare provider about what might be going on and how it can be addressed. Again, you can find more resources for all of these things in your client resource list.